Hello, everyone, and welcome to week 6. We're going to talk about ADHD and eating disorders. Your assignments this week are Toussaint and Fitzpatrick, chapters 13 and 16, Bolin, chapter 13, and then looking at the DSM-4 on eating disorders and ADHD. There's also a quiz and a nice short little video for you. So, eating disorders, we're going to look at bulimia nervosa and anorexia nervosa. So, types of eating disorders. Well, you have, like I said, bulimia nervosa, anorexia nervosa, binge eating disorder, and there's other types of disorders like pica, rumination, restrictive intake disorder. Let's look at the epidemiology. Bulimia nervosa, lifetime prevalence around 1%. Here you see Princess Diana. She admitted to having a history with bulimia. 3 times more prevalent in women than men. Median age of onset is 18. More common in Caucasian adolescent females and with higher socioeconomic families. Anorexia nervosa, some sobering statistics here. A study by the National Association of Anorexia nervosa and associated disorders reported that 5 to 10% of anorexics die within 10 years after contacting the disease. 18 to 20% of anorexics will be dead after 20 years, and only 30 to 40% ever fully recover. It is a big challenge, 10 times more prevalent in females than males. The mortality rate associated with anorexia nervosa is 12 times higher than the death rate of all causes of death for females 15 to 24 years old, and 5 to 1% lifetime prevalence. And also, I should note, I didn't have it in here, has the highest mortality rate of any of the mental illnesses that we are talking about. Remember, anorexia is a clinical term, and anorexia nervosa is a diagnosis. So be careful not to mix those up. Some risk factors: higher income brackets, typically Caucasian females, sports restrictions, uh, especially for boys, wrestlers, gymnastics. Parents will focus on female role models with higher standards and focus on appearance and winning. Trauma, don't forget trauma. You've seen this all through this course. Trauma, how it affects people and their lives. So, bulimia nervosa, it's a catch and released. It has to include binging, which is consuming large amounts of food than an average person might consume in a given period, such as pizza and cereal. And it may be either purging or self-induced vomiting, laxative abuse, enema use, diuretics. And it can be non-purging types, such as excessive exercise, use of diet aids, or other medications, such as levothyroxine or stimulants. So, true or false? People with bulimia nervosa are either obese from binging or cachectic from purging. Well, that's false. People with bulimia nervosa are more often within a normal weight range. And then people with bulimia nervosa are often terrified of becoming fat and base their self worth on body size. And that is true. A defining quality of anorexia nervosa and bulimia nervosa is basing their identity on external image. Some biological risk factors: there's an S allele carriers with decreased serotonin transport, abnormal levels of dopamine, interestingly, a higher birth rate, lower testosterone levels, women greater than men, and severe childhood obesity. And one other thing, yeah, severe childhood obesity. So anorexia nervosa, it's not just about starving yourself. Maybe the restricting type, counting calories, limiting intake, binging, purging, believe it or not, sometimes we don't think of that, but they can binge and or purge on foods, may not meet the criteria for bulimia nervosa because their weight is abnormal. Binging and purging only occurs during episodes of anorexia nervosa. What do anorexia nervosa and bulimia nervosa have in common? Well, there's preoccupation with body image, frequently co occurring with borderline personality disorder, depression, anxiety, PTSD, and trauma. Also, control is a big, big component of this disorder. So, how do we assess for eating disorders? Well, there are standard tools that you see here, looking at your population. But I would screen everyone. I frequently try to remember to ask every patient how are they eating, how's their diet. Sometimes I'm surprised when I hear things from them. So observe their comfort level, comments made while taking their weight. My MA, I can hear oftentimes weighing my patients, and I do hear frequent comments about that. Ask about any concerns with their weight. Do they count calories? Do they ever eat more than? Do you think you eat more than you should? Do you take diet pills or laxatives or exercise excessively? Do you ever try to make yourself throw up or lose weight? And some assessment pearls, timing duration of exercise. Are they exercising for hours versus, say 45 minutes to a half an hour? Monitor for abuse of meds with weight loss risk, i.e., levothyroxine or stimulants. Are they fidgeting, restless, standing when they could be sitting? Blind weights, so they're lifting weights and doing things. Frequent duration of bathroom use. And then we need to watch our language, watch it with our patients, watch it around our coworkers and families. So you hear things like, "Oh, you're so skinny," and "Your weight is terminally normal. You have nothing to worry about," and "Oh, you look like you've lost weight. You look great." How many times have we said that or heard that ourselves? So just be mindful of that. The effects of anorexia nervosa and bulimia: dental caries, periodontal disease, esophagitis, Mallory Weiss tears, diarrhea, rebound constipation, Russell's sign, that's hand calluses. Typically, that happens in bulimia. Dehydration, muscle wasting, body temperature dysregulation. They can have dry skin, brittle hair, cardiac arrhythmias, blood pressure abnormalities, cardiomyopathy, osteoporosis, amenorrhea is a big one, difficulty concentrating, mood imbalances, syncope. So again, remember that concordance we talked about, concordance and treatment, making goals together. You want to be non-judgmental. Avoid statements such as "you're going to have to put weight on" or "you're going to die." Um, Watch your language. Normalize. Don't sensationalize. And be empathetic. I'm with you, not against you. Pharmacologic treatment of bulimia and anorexia. So bulimia, you use fluoxetine is FDA approved, most studied for and doses up to 60 milligrams. Co-occurring depression and anxiety. See this a lot. Um, Bupropion is contraindicated, Wellbutrin, due to seizure risk. Remember that. Always keep that in your mind. You will likely see that as a board question and on other exams as well. Be careful with lithium if they need that. Anorexia nervosa. Olanzapine Zyprexa increases appetite, decreases anxiety, and avoid medications with dietary restrictions or weight loss as a side effect. Naltrexone, Rivia, is uh, been shown to be helpful due to its effects on starvation on endogenous opiate receptors. And in acute stages, can also consider an anxiolytic before meals. Some patients can get very anxious before a meal. Other treatments, hospitalization may be necessary, and don't be afraid to do that. Structured, monitored meals and bathroom breaks in the hospital may increase dependence on others, and you want to avoid power struggles. Refeeding, they have to work closely with a dietitian. Again, In hospital, they have to, be closely monitored. This is usually some special type of hospitalization, not a typical psychiatric unit. Um, Supplements such as Insure, Boost are given, but they can be dangerous if not done correctly under medical supervision. And then, of course, therapy, DBT for borderline personality, trauma, cognitive behavioral therapy. So I want to talk about a patient I just recently saw. His name, and I saw this young man in coverage for my psychiatrist that I work with, who had been out. He's an 18-year-old white male. His father was physically abusive, mentally abusive for many years until his mother finally divorced, and left him. He has an older sister who developed a brain tumor, and mother was frequently going to the hospital for treatment to be with her daughter. So he was left alone to care for his younger brothers and was, um, you know, having to do everything around the house, feed them, cleaning, and help to raise them. He suffered from social anxiety and panic attacks and began restricting as a late teen. When I saw him, like I said, he's 18, so he began probably about the age of 15 to restrict his food. So what's been happening with Justin? Well, he was started on medication, working with therapy to help treat his disordered thinking and eating. We referred him to therapy also to address trauma, loss, and control. Engaged his mother and his grandfather, who lived with him. They had lived with the grandfather now, and began to push Boost. And ultimately, were increasing his meals to 3 times a day, having frequent visits during his acute phase. He would have times, or has had times, where he struggled more than others. But he's been putting on some weight and seems to be doing well right now. But again, he's monitored pretty closely. Binge eating disorder. This is something you'll see maybe frequently. It's often hidden. I think this takes place with a lot of young guys, particularly who are playing sports. Diagnosis features, it can be episodic, lack of control, guilt, depression, at least 1 time a week for 3 months. There's no compensatory mechanism such as no calorie counting, purging. It can be mild, moderate, severe, or extreme. And then some food for thought. Most, but not all, persons are obese. That's something you want to think about. Obesity may not be caused by binge eating. 12-month prevalence for females is 1.6%, and for males it's 0.8%. More common in those seeking weight loss treatment than in the general population. So, how do you treat binge eating? Well, we use Vyvanse. It's the only FDA-approved drug for binge eating disorder, and it reduces the frequency and intensity of binge eating. Topamax is kind of off-label that you can use. SSRIs. Data is inconsistent, but may help with congruent depressive episodes. And then cognitive behavioral therapy, dialectical behavioral therapy, support groups. And be careful that support and therapy are appropriate for binge eating disorder. You don't want them to just have any type of therapy. It has to be more specialized, personalized for this. And that's true for any type of eating disorder. So, looking at obesity, that is a BMI greater than 30, maybe the cause of multiple factors, lifestyle, medications, genetics, childhood trauma. Treating obesity, some clinical pearls. Monitor labs regularly, including H1C and lipids. Checking the weight at every visit. Consider weight gain when selecting medications. Consider your population, i.e., their socioeconomic uh, issues, and be a health coach. Every little bit matters. Remember, it's not always a happy Thanksgiving, and be mindful of our food centric holiday and cultural norms. And Thanksgiving can be one of the most difficult days of the year for people who struggle with eating disorder. So, in summary, control is a theme among the major eating disorders. Recovery is possible, but relapse is common. There are medications to help, and remember unconditional positive regard. We're going to look about at attention deficit hyperactivity disorder. Yes, you see this in your adults. So there's three types here. You have combined, then you have predominantly inattentive, and then predominantly hyperactive impulsive. I'm sorry, that was three subtypes. And so some of the basics. Prevalence ranges from 2.5 to 4% of adults. Strong genetic risk, up to 50%. Impaired frontal lobe functioning, as well as frontal striatal abnormalities. Hyperactivity may be affected by basal ganglia dysfunction and may include cerebral dysfunction and other physiologic brain differences. Dopamine and norepinephrine are also implicated. And is it nature versus nurture? Something to think about too. ADHD myth versus fact. So myth. Students with ADHD typically make poor grades. Well, that's fact. Many children and adults can succeed academically without or with medication. Myth. ADHD was just invented in the 1980s. Fact. It was first identified in the 19th century. It's not ADHD if it wasn't diagnosed as a child. Fact, symptoms may not have been recognized, or parents may not have sought treatment, or if they did, which I hear this frequently in my younger adults, not my older adults so much, but my younger adults, that the parents didn't want to start them on medication. They were afraid of it. I hear that frequently. Some diagnostic criteria interferes with functioning. Um, at least 5 symptoms for at least 6 months. Careless mistakes, fails to pay attention, difficulty sustaining attention, distracted, doesn't pay attention when spoken to, does not follow through on instructions, difficulty organizing tasks, explicitly avoids undesirable tasks, frequently loses items, distracted by extraneous stimuli, forgetful in daily activities, such as turning in assignments, paying bills. Assessment. Here's what they say. It feels like two squirrels running around in my head. It's like a train, and I see a speck of dirt on the track, and it causes me to completely derail down the mountain. I would sit down to do my homework at the computer, and 4 hours later, I realize I've been watching YouTube videos about penguins or TikTok. It's all just noise. So, assessment. You have your standardized tools, such as your adult self-reported scale. That's WHO endorsed. There's also some nice computerized screenings that you can do now for people, adults. Past history. What was their grades in high school? What was college like for them? How they do in grade school? Their job history, including history of work-related discipline, substance abuse, including caffeine. Many times I have found and have been finding that patients self-medicate um, with other substances, including caffeine, to help deal with this brain that won't stop, that won't shut down, that's constantly moving. Always using your mental status exam to do a nice assessment there. And my two favorite assessment questions, they're not evidence based, but what does your space, your room, office look like? I.e., in terms of cleanliness, clutter. Could you find a specific item if I asked for it? And then how do you respond to caffeine? Most of us, it'll make us jittery. Someone with ADHD, they'll calm down and feel a little better. So you want to rule out depression or anxiety. Remember, depression and anxiety can have similar symptoms, similar presentation, especially anxiety to ADHD. So you want to rule that out. Borderline personality disorder, mania, psychosis, or substance use. And I just want to again make this caveat, and I want to make this very clear to all of you. A person with ADHD, or I'm sorry, a person with bipolar 1 or schizophrenia, psychosis, or any type of schizophrenic disorder should not get or be prescribed a stimulant and or even a non-stimulant medication. And why is that? Well, because where do those medications work? They work on the dopamine receptors, right? And so when we do that, you can put these patients into psychosis. So please, if you learn anything from this lecture, I want you to remember that if you do have a patient who's bipolar 1, and you have them on, and they're on a medication for ADHD. I have one or two, but I am also very closely monitoring them. Um, and they're on antipsychotics as well, and mood stabilizers. But you need to monitor them carefully. I would not give these to a schizophrenic patient, a stimulant, non-stimulant treatment for ADHD, just because it can put them into psychosis. So please always remember that. Let's look at Lisa's story. Lisa is a married 34-year-old female with a long history of substance use disorder. And she's been in successful treatment for over a year. Her substance use doctor sent her to me. she's been she's had trouble holding a job and keeping a job, couldn't focus, complete tasks, and went through multiple jobs. And she'd struggled since a child with staying focused and being easily distracted. Grades were poor. Um, she said her sleep was impaired because she just can't keep up with housework and her children, and her mind was always going. She admitted that she recognized it as a problem for many years, but hoped things would get better after not using substances, and admitted that the reason she used substances was to slow her brain down, slow things down for her, um, because she just could not seem to get control of that. And so we ruled out other diagnoses, obtained records, did a nice screening with her, worked very closely with her and her substance use disorder treatment, and started her on Vyvanse, and she did amazing. She was very engaged in her therapy. Of course, I monitored her closely. She was able to obtain a full-time job that she loved, was very successful, became a valued employee, and she's thriving and doing great and feels like she has her life back, um, and is engaged in treatment and everything else that goes along with that, um, and not using other substances because she's monitored frequently for that, but has done amazing. So that's a good success story. So we're going to look at some medications, the stimulants. You have your methylphenidate, Ritalin, and derivatives. Your amphetamines, Adderall, and derivatives. Remember, timing is important as a dose. You want these patients to take them typically in the morning, um, because that will keep them awake. If they're working during the day, obviously. And know your onset of action, duration, and half-life, very important. Also consider the cost. Some of these meds are more expensive than others. So some clinical pearls for you. You don't want to underdose, meaning, you say you're starting them at 5 milligrams a day for 30 days before their next increase. That's not going to probably help anyone. So follow up, and typically I do maybe 2 weeks. They can always sometimes communicate with you through a patient portal, see how they're doing, or email. Consider your population. Is there a risk of diversion? Consider, and I do this regularly, regular drug testing, pill counts. I do this. You want to rule out any type of substance abuse. If I have patients who are using substances and smoking marijuana, well, I will not prescribe their stimulant medication. That's my practice. So check your state's PMP regularly. You can see what meds they may be getting. I also find I have a problem with someone um, getting a stimulant and also taking a benzodiazepine because they work against each other. So psychological testing is not the diagnostic standard, though it can be helpful. And many states will not allow refills, but do allow post-dated prescriptions, and will likely suppress appetite and cause weight loss. So you want to assure that they're getting adequate nutrition. I always ask that, and also their sleep, that their sleep is good, um, because it can affect sleep. Some non-stimulant options are atomoxetine, Strattera. I use this one frequently. Remember, you want to check pregnancy testing. It's uh, can be harmful for pregnancy, and you always want to advise your patients of this. Uh, it can have some negative side effects. It's a for those who are poor metabolizers of CYP2D6. Bupropion, Wellbutrin. Use that a lot too. Of course, again, watching your population is contraindicated in bulimia, contraindicated in anyone who has a seizure disorder, so you can't use that. Um, and Guanfacine can be used. I don't use this a lot, but you can use that. Again, you have to remember that it's sedating, can lower blood pressure. There's a new one here, Kelbri, Valoxazine. It's a newest medication. I use this one a lot, and it works great. I use it in my adult and child population. It's not for everyone. It's been around for many years. It was used for depression, but then it was rebranded and is now used for ADHD treatment as a non-stimulant. I've had a great success with this. Not with everyone, but with most people. Can cause some sleepiness and irritability. And so, why do you want to medicate for ADHD? Well, you can have improved quality of life, and just always make sure, though, that the benefits would outweigh the risks with these medications. And then other supportive treatments, as we've discussed multiple times, therapy, focus on adaptive skills, accompanying emotions, lifestyle modification, reducing disparities, school and workplace accommodations, exercise, helping patients find their passion. And so, in summary, ADHD is a diagnosis given in adulthood, can be debilitating, can look like many other mental illnesses. Treatment options can include stimulants, non stimulants, therapy, and recovery is life changing for many of these people. Again, be mindful that you will also have patients who abuse these substances. So be judicious with your screening and treatment. And don't feel like you have to treat these patients all the time, too. Um, but they do deserve to be treated if they truly have ADHD. And now, next week, week 7, we're going to be looking at substance use. There's your readings there. There'll be a TED Talk video you can watch. You'll have your final exam and have your buprenorphine waiver training for all of you. All right. Have a good week.